Hi, everybody. It's Dr. Kat Gallus, and we're about to start the new year with another installation of Carpools and Cannulas. And tonight we're going to talk about gynecomastia. I'll be joined with Dr. Jennifer Greer, who's hopping on right now. And your internet's working as well as mine is, so that we're going to get on. Hey there.
Happy New Year,
Happy New
2023,
Year.
and 9 days into it already.
I know. I know it's 9 days because I'm doing one of those dry Januaries and it's torture.
I have a dry wine. Does that count? Yeah.
Yes, that counts. I'm drinking my concoction of ice, that flavored water and LaCroix. Oh, and my dog's here. Just 23. Okay. So,
Yes.
So I hope you had a good holiday. And I think we took a break for the holidays, but we were going to talk about gynecomastia, which surprisingly we hadn't done yet.
We do have a lot of female followers, but I still get a fair number of gynecomastia cases.
Yeah. I did more of them when I was in the Navy, in the military, but I sort of had like a minor following. And they joked because all of my patients were heavily tattooed for whatever reason. So on the occasion when somebody wanted to see before and afters, and I was like, I swear I operate on people who are not tattooed as well. It's just, and I'm not talking like one tattoo. I'm talking like Travis Barker
I always love
level,
when they get up to like the anterior neck. And hi, Amanda, I see you watching. So when you were doing it in the Navy, was that covered?
Yeah, so it was covered if they met certain criteria. Pain was one of them, which is, very hard to, But they were actually even doing a study at the Breast Cancer Center, the Multi-D Center, where they don't have breast cancer. We can clear that up right now. But they were treating out of that center, they were treating them with tamoxifen, which is a known treatment. So they were running a trial to see if tamoxifen.
I don't know. I feel like
I know.
So a lot of them were not small excision under local.
Yeah, absolutely. So I got a lot of traffic from people who were like, "You want me to take an estrogen blocker?"
Although I guess it makes sense, especially for the exogenous.
Yeah. Mm-hmm. Yeah. So, all right. Well, why don't you tell everyone what gynecomastia is?
So gynecomastia, also known as man boobs. I've heard them called moobs also. It's actually glandular breast tissue because of hormone imbalances. So usually around puberty and then senescence, so like 50s, 60s when testosterone levels drop. But I think with marijuana use being legalized so many places, that can also increase risk of gynecomastia, so can other medications. And then people also confuse the glandular tissue itself with just extra fat over the pec muscle and thinking that's gynecomastia, but truly it's the glandular tissue.
Right. So it's not associated with the risk of cancer. It is associated either with a hormone imbalance or a medication, or it can be our favorite medical word, idiopathic. We don't know why, but it's common. Yeah, you're right, in the teens. Now, I have operated on teenagers who had gynecomastia, but out of teenagers that do have it, like about 2/3 of male adolescent boys will develop gynecomastia, but then about 2/3 of those will see it resolve spontaneously. So you certainly don't want to operate on someone who, has had it for 6 months, is 15 years old, and is likely to not need surgery. So you just kind of have to ride that out. Do you, so then there can be some things like liver problems, some other physiological problems that can lead to it, and then medications. So it comes up all the time. Do you test your patients? Do you get labs, or do they get screened?
But truly all the patients I've seen, it's been there for more than a year. It's stable. It's not going anywhere. So.
Right. It's actually, I've had tougher cases where it was an older male patient who was on a medication to treat, like, for example, prostate cancer. He couldn't change off of it. So the incidence of recurrence is pretty high, but what are you going to do? The alternative was radiation.
In that case, yeah.
Yeah. Yeah. So it was a little, that can be hard. So yeah, so I mean, usually by the time you see us, you're down the pathway for surgery. But I mean, somebody needs to do that study and look at the incidence of gynecomastia in states who've legalized marijuana and what that's done, right? I just heard on the radio, there's a study that was just done. They looked, I think Colorado is the state that's had the longest legalization. And they looked at like the number of poisoning events for children, like people who call the poison control hotline and or show up in the ER for accidental ingestion of marijuana before it was legalized and now, and you can imagine
it's so much of it's in edible form.
Right, and it looks like a gummy bear, and I mean, or something
packaging
stupid.
Has to really not look like candy, anyway, but it's still, a brownie's going to look like a brownie.
It does. I mean, if people are going to eat pods for Tide Pods, then, you know, I feel like a gummy bear is going to be a gummy bear. Well, actually, I think they can't even be in a gummy bear shape. So I applied for a dispensary license the last round in Ohio, so I know a ridiculous amount about at least cannabis in Ohio. We didn't get the license, but like the gummies can't even be shaped like a gummy bear. They have to be just like round. The names have to be very not geared toward children or sound anything like candy, which is interesting. Yeah. Well, that's smart. And like the tobacco company. But so I wonder if somebody who's looked at it, somebody should do a study. Jeff Janis, just throwing out a name, just kidding. Somebody who's always doing research. Be perfect for him, to look at states that have legalized marijuana and then see if the incidence of gynecomastia has increased. It would be easy to figure out. So, anywho, once you've seen us, you usually have some problem that's not going to get solved unless you embark on surgery, right? And what's your usual technique? So it's interesting because most of the people who come in with gynecomastia have a combination of excess fatty tissue and the actual glandular tissue. And for those of you who don't know what that glandular tissue feels like, it's like a little firm ball right behind the nipple. And it can be tender or not. It can be one or both sides. So that's the true gynecomastia part. It's generally a combination of liposuction and then direct excision of that fibrous part, because that stuff doesn't come out with lipo. Right. And yeah, and so that as per usual, we're on the same page. It's so funny how we like train in totally different places and times, and we do everything the same. Yes, it is weird. Yeah, so combination, and because there are more than one way to do it. I've even reviewed papers for the journal where someone's presented their unique technique of gynecomastia excision or whatever, and then the paper gets rejected because you're just doing liposuction, direct excision, and then he always space on he's excited about the gynecomastia because he's got the little fluffy belly. He's hoping this will apply to him. Yeah. So of techniques, you can do liposuction only. I find that ends up being a fail because that little bit of the tissue doesn't go away, and even if it's just a small amount, it ends up leading to a puffy nipple. Even if the rest of the with just the puffy nipple, rest of the pec is well defined. There's no extra fatty tissue. It just makes the nipple look puffy. So if you have that, you may not realize that's gynecomastia, and it's very easy to treat. I mean, I do these cases under local if the patient wants it. Sometimes they would prefer to have general, but you can definitely do them under local and keep people comfortable. Just the local, just excision only, or excision and lipo and liposuction under local. But you just tumescence slowly. I mean, yeah, right. Kind of not great with pain. No, I mean, some of them are, some of them are. No women. Yeah, I think more of my
male patients prefer to be under general anesthesia.
It was
Although
so-
one of the funnest cases I ever did on an awake patient was a gynecomastia case. And the patient was hilarious. I was like, you're not going to remember any of this tomorrow. He's like, I'll remember your cell phone code. You just gave it to your nurse. He came in his follow-up appointment. He's like, 1998. I'm like, oh, that's not, obviously, because that's only 4 digits.
Ooh.
But, oh, we have a question. Breastfeeding. Ooh, good question. 6 months
Breast
generally is minimum, because it takes a while for that milk to dry up, especially if there's any intermittent nursing in there. And even if you haven't nursed or pumped or anything for 6 months, there will still be some milk in there when we do your reduction.
Yeah, and that's not the end of the world, but what your breasts are still maybe changing size, so you don't want to hit a moving target and over resect or under resect. So it's nice.
And you don't want to get healing problems too. You don't want like a galactocele or fistula. Or...
Yeah.
Yeah.
A large abscess in the left one. Oh, that's a drag.
I'm sorry. I've had patients where this happened. Usually the drain should be coming out soon unless it's still putting out a... Oh, thank you. I mean, I've had that happen too. Sometimes that just does happen.
I mean,
So wonderful.
I'm in Cleveland.
Well, I look forward to meeting you.
Year. Oh, good.
And congrats on your baby.
Yeah. Yes, that is always, I don't want to miss on that. I usually demand that those patients bring their baby.
We are so baby friendly in my office. We're like, you have to bring your baby for your Botox? We'll hold it. Okay. Yeah, I'll totally hold your baby while we talk.
You're just in over. Okay, well, so excision and liposuction, some kind of combination, right? Almost always need excision, almost always. Sometimes you don't need liposuction. That's like on a super, super skinny, 2% fat person who just has that little glandular bud. But there are other techniques or things that have been explored to see. I've seen it done a couple of different ways. Where do you put your incision? Is it around the areolar complex?
This is one of those things that I fiddled with, because for the lipo, I feel like having the incision laterally is much easier than trying to do it in the nipple. And then I used to do an incision right on the edge of the areola to excise, but then I forget who, somebody pointed out that like straight across the areola actually blends in better and heals better. So I've done that too. How about you?
Yeah, I like going around the areolar complex. I know that the problem can be that that can dent in a little bit, and I've seen cases that's happened for you know, I think if you're super careful on how you close, and honestly, the premise of that paper that got rejected was making sure that the tissue underneath is stable so you don't end up with that. And I think, you mean common sense, but I feel like it can look a little weird if it goes right across the nipple areolar complex. And honestly, as per usual, depends on the patient, right? It depends on what their areola looks like. If this teeny tiny thing might be hard to go all the way around. I don't mind the little incision in the axilla if I need to for liposuction. I try to do it all through one incision, but again, it depends on the patient and what we're accomplishing. I worked with a guy at Kaiser who would make a random incision on the chest, which I thought was wild. But then he said, oh, well, then it's not stigmata of having gynecomastia surgery.
Yeah.
You can say you had
I've seen that.
Yeah, so he put like one scar here and one scar somewhere else on the chest. I'm like, I guess so, as long as you clear that with the patient.
I mean, once they fade,
whatever,
they're pretty hard to
and then you can't see it. Yeah. And then also I will sometimes add Renuvion. I know I use that radio frequency device if somebody is a little bit fluffier or has some lax skin, because then in addition to I'll tighten everything up. I do, because you don't want to have to put a bunch of incisions on someone's chest, because then instead of being insecure about having man boobs, you're now insecure about these wild incisions. I did work with a guy who came and was like a reservist in the Navy, came out, and he was in practice on the East Coast. And instead of excising the glandular tissue, and I've heard of this other places, they use like a cartilage burr to like burr it down and then suction it out. I just never really very satisfying.
I've done rhinophyma cases with like trying to do the dermabrader, and it just sounds slippery and difficult. Yeah.
Mm-hmm.
I don't know. I know where I trained in residency, one of our attendings was really, really big on having the patient build up pec muscles beforehand so that they would see a better result. He's like, you got to build the foundation. So, I mean, we were mostly trauma. So we did very few gynecomastia cases, but he'd be like, go do some bench presses, do your push-ups, and then we'll talk.
That's funny. Why? Did he have a regimen? Like start with 10 push-ups?
He might have. I don't
like,
even know.
So
but then I remember seeing a video of Simeon Walls who does fat grafting like into the pec muscle to build it up.
Mm-hmm. I know. I have seen that too. I was going to say the high def guys who do liposuction and then turn around and do fat injections in areas of where muscle should be. I feel like that's cheating.
You're not actually stronger. I mean, you can't actually push up.
Yeah, you don't have now. You just have weird fat where your muscle should be. Like, what does that feel like? The delts and it looks crazy. I do try to make it consistent with the rest of their torso, right? So you don't want to do a chiseled chest if someone overall not, some super cut model. Yeah, that's fine. You want to get it so that the contour is consistent with the rest of them, which I think is a nice approach. Do you use drains?
I have started doing Tapafoam, vest, and then I wrap with an ace wrap for 2 days. I love that.
Okay. Yeah, I do a vest for sure. I don't ace them on top of that, but that's not a bad idea. I started acing all my breast
reductions because I got a seroma or two early on when I stopped using drains. Now I just, everybody who gets chest surgery gets wrapped. Pretty much.
I just put them in
I wrap
or vest. Yeah, so I like the
2 layers. Yep.
You're like, nope,
keep it on.
We're still gonna Yeah, I just put them in a vest, but I like the ace wrap for people that you might be a little worried about. I don't like putting drains in. Everybody hates drains, as the person who commented earlier. So if you don't need them, I try not to use them. With men, the reason that sometimes people consider doing drains is just because they have a little bit higher rate of postoperative bleeding just based on their blood pressure. But I feel like that, as long as you're careful. Do you do any top surgery? Speaking of
commonly, I've done some like very aggressive breast reductions for non-binary. I've done some male to female with implants, but not a ton. Yeah.
Oh yeah. Yeah. For everybody listening, top surgery is when you go from female chest to male, and it involves, basically a very aggressive gynecomastia procedure. It can involve incisions, what they call double incision, or just if they're not very big breasted to start with, just going through that periareolar incision, or it can be much more dramatic. The only reason I brought it up is a lot of those patients are on testosterone, so they're on hormones because they're transitioning, and so that puts some. I've worked with surgeons. I don't really do top surgery, but when I was at working for Kaiser as a per diem, we would do some. And some surgeons chose to take them off of testosterone for weeks before surgery because it increases the risk of bleeding. I think people tend not to do that anymore because it made people, everyone miserable. Like when you take
birth control for blood clots. I mean, yes, blood clots are bad, but so is pregnancy if you don't want it.
One has long-term implications if you get pregnant.
I mean, that right there increases the risk of blood clots. Pregnancy.
Right. Yes, true. Yeah. So anyway, so because of the higher testosterone of a male patient versus a female patient is why some people I know choose to use drains. But like I said, I think if you're not sticking a cartilage shaver in there and praying for the best,
especially if you switch to mess it with some epi and kick it to hemostasis.
Yeah. Yes. Yeah. So I find that the hardest thing about gynecomastia surgery, similar to tummy tucks, but in that patient population, is the post-op. not pain, it's just the recovery. Because I did, when I was in the Navy, I did a fair amount on like SEALs and Marines and these like superpower guys. So not a lot of body fat, not too much liposuction, but a direct excision. And what you don't want them to do is like a week out, go bust out some pull-ups, right? And so I think that's, yeah. So what's your, like, what do you tell these guys for the real,
4 weeks.
Gym rats or whatever?
I tell them 4 weeks and they sometimes hate me.
I know it's really hard to not work out. If the whole reason you're there is because you like the way your chest looks, except for this, and you really spend all this time and energy working out and doing those push-ups or whatever, and then you're like 4 weeks, but it really is a short time in the grand scheme of things to have.
Right. And if you cause a problem, if you cause a hematoma, and then you have to go back to the OR, and then that restarts the clock, and it just takes longer for everything to go down. So,
right. Yeah. I think it can be a little daunting for people to take. But if you can find that time and commit to the recovery process, then then it's easy breezy. And I get it. I like my eyebrows done, and I didn't want to take 7 days off of not sweating.
I can definitely take 7 days off of working out without. I mean, like,
I know. I love those people who are like, what?
Not a problem. Well, and the other thing that drives people nuts too, like, we're not talking 4 weeks of no push-ups or bench press. We're talking 4 weeks of no anything. Because what happens is your blood pressure increases when you're working out, and then you can spring a bleed. I had a breast aug patient who started working out week 3, and not week 4 got a big hematoma. We had to go back to the operating room. And I didn't know she started working out. I go to talk to her partner afterward, and he's like, she was running. I'm like,
oh, yeah. Yeah, no box jumps. I know you're not
no
using
squats.
Your chest,
don't even get the 5-pound dumbbells. Just don't do it.
Yeah. I get that. Can I Peloton? No, you can't Peloton.
Yeah.
Please just take it easy. You can walk. And by walk, I mean just walk. Do not go hike toward your
I literally tell them, like, 2 miles, heart rate under 100. Because I had somebody go for a 10-mile hike the week after an eye lift. Their incision dehiscibit.
I get it. Like, once you can't do, you're told you can't do something like, I don't know, drink for the month of January, then you really want it.
It is.
It's just human nature. I've had one of my favorite patient asks was post mommy makeover. We had talked about how she's planning a trip to Hawaii like 6 to 8 weeks after. I was like, it should be fine. I mean, you should heal and be healed. But I am in San Diego. You're just going to be hanging out at the pool. Like, you can show off your body, but like,
if you have any open areas at all. Yeah.
Right. So I see her in like right before she's supposed to leave for Hawaii, and she's like, can I scuba dive?
Oh, like, maybe. I mean, 6 weeks? I don't know.
I was like, do you oh, hi neighbor. I was like, do you scuba dive? Like, this is news to me. Usually I get to know my patients a little bit, and if they're an avid scuba, I felt like I would know that. She's like, oh no, I've never scuba dived. I'm like, so let's just be clear. You want to start this Hawaii trip 6 weeks after surgery? She's like, yeah, I heard. I go, are you even qualified? She's like, no, but you can do the
how about not?
No.
Next trip?
This is
right.
You can hold a margarita or whatever your Mai Tai at the pool, like we discussed. Yeah. Please do not start scuba diving. But that is just because, you're supposed to lay low. So that's when you're like, wow, I think it's a good time to, take up fencing or something random. Things you never thought of. And then
maybe I'll get horseback riding lessons or parasailing.
Yeah. Yes, parasailing. I know. I should just make this long list of things not to try. Just let's cross these off for the first 6 weeks. Anyway, well, we should figure out what we're going to talk about next, and then I think we'll wrap up because I got to go interview a virtual call.
Yeah.
I don't know. We can chat about it unless anybody has a suggestion for put it in here.
Not talked about in a while.
Talk about breastfeeding. Yeah, or something we haven't covered. Let's see. I'm trying to wave to people. Okay. What do you want to talk about breastfeeding and breast surgery?
We can, and we can talk about all the fun, commonly held ideas, like whether you should wear a bra all the time or whether you should not wear a bra, according to some article about French people. Yeah.
Yeah, that sounds good. Yes, because I do have patients that say, I want the surgery so I never have to wear a bra again.
If we're doing
which I
rejection
get,
to an A cup, done. You will not have to. But yeah. Okay, we can talk that. That'll be good.
Okay. All right. Well, it was super good to see you. Are you going to be? You're going to be in Charleston,
I'm bringing
right?
my boyfriend.
No?
It'll be fun. Yeah.
Nice.
Yeah. Pulling the Megan. I'm like, she brought her boyfriend.
Yeah.
I'm bringing my boyfriend.
As long as he can take the overwhelming estrogen, I think he'll be fine.
Yeah, I think he'll be
most
totally.
People can.
And he was in the Navy. He's in the Navy. He's in the reserves now, so you guys can chat over that. Yeah.
Oh, yeah.
Yeah.
We can discuss that.
Fun.
All right. Awesome sauce.
In 2 weeks I'm here,
okay.
and then I'll see you in person in Charleston.
Sounds good.
Bye,
all
you
right.
too.
Bye. Have a good night.